Good morning. My name is Wayne Bowers. I am the current clinical director of the eating disorder program in the Department of Psychiatry at the University of Iowa. I want to thank you for joining us for the second of our webinar series, and it's brought to you by, as a member benefit for the Academy of Eating Disorders. We hope you will enjoy the benefit from this webinar entitled DBT Treatment Strategies applies to complex multi-diagnostic patients diagnosed with eating disorders, a focus on behaviors that interfere with treatment. Before I quickly introduce and turn it over to our presenter, a couple of housekeeping details. There is a feature you can use to type in any questions or comments you may have. It's called the questions feature. We encourage you to put your questions down as we go along. We will collect them and address them at the end of the presentation. Please include your name and where you are from with your questions. If you experience technical difficulties in participating in the webinar, use the questions features to contact the staff. AED Director of Communications, Monica, will be standing by to help you. At the end of the webinar, you will be invited to share any comments you would like to share. We want to hear from you, including hearing from any ideas you have about future webinars. Now, it is my pleasure and actually honor to introduce our presenter. And just a little caveat, I want to sort of personally say Lucine was the individual who introduced me to the use of DBT in the treatment of eating disorders. And she was very instrumental, and she just found this out, in my attempting to integrate it into the use of cognitive therapy and DBT, and I think I've been partially successful, so I want to give her lots of kudos for helping me grow. Lucine, who is a PhD and a fellow in the Academy of Eating Disorders, is the Chief Clinical Officer of the Emily Program and an adjunct assistant professor of psychological sciences at Case Western Reserve University. From 2006 to 2014, she served as the clinical director and co-founder of the Cleveland Center for Eating Disorders, a comprehensive eating disorder treatment program. Her research and clinical interests include using empirically founded treatments to inform clinical programs. She provides workshops on CBT and DBT in the treatment of eating disorders internationally and has published in peer-reviewed journals as well as invited chapters. Lucine has been elected fellow and served on the board of directors and as the co-chair of the Borderline Personality Disorders Special Interest Group of the Academy of Eating Disorders. In 2013, the AED awarded Lucine the Outstanding Clinician Award to acknowledge her contribution to the field of eating disorder treatment. It is my pleasure to present Lucine Wisniewski.
Thank you, Wayne. Good morning or good evening, depending on where you are and how you are watching us. I'd like to thank the AED for inviting me today to give this workshop. It's an honor indeed, and for Wayne for that lovely introduction. I want to give you a little overview about what we'll do in the next hour. There's a lot to discuss here. And I believe that we'll have about an hour and then we'll have some time for questions after that. So as Wayne said, if you have questions, write them down. So first I'd like us to talk a little bit about what makes people difficult to treat. Like, how do we think about that in the first place? I'm going to give you a case example, talk very little bit about DBT, because this is not necessarily, it's a DBT talk, it's framed in DBT, but it's not necessarily how do you do DBT. The aspect of DBT that I will talk about targets, and how do you prioritize multiple behaviors in a session, or even conceptually overall in a particular case, when you have multiple problems to be able to address. And so we'll talk a little bit about how you do that. So that's my plan. So the first thing I'd like you to do now, hopefully some of you understand this cultural reference. This is Elaine from Seinfeld. Elaine had gone in to see her doctor, and of course while the doctor, and this was when there was paper charts, so obviously this is old, that Elaine looked in her chart and it said that she was difficult. And she was really quite distressed about this. So whenever I think about difficult patients, I think about Elaine and Seinfeld. But what I would like you to do in this moment is if you could grab a piece of paper and a pen and take just 2 minutes and write down for yourself, when you think about a difficult patient, what makes them difficult? What exactly, how do you operationalize that for yourself? So grab a piece of paper and a pencil or a pen, a writing utensil, something to write on. And I'm going to just give you a minute or two to write that down. What makes your most difficult patient difficult to treat? Now don't worry, I'm not going to make you read them and you're not going to have to share them with anyone. So this is really just for you, for your edification only. And as we go through the webinar, if you have other thoughts about what makes your patient difficult, please add it in there, because as I talk about my theoretical case, who's Nadia, you may get some other ideas. It may jog your memory about what for you makes a patient difficult to treat. So let's use an example of Nadia. She's a 23-year-old female patient with a 9-year history of anorexia nervosa. She's had repeated hospitalizations as well as residential eating disorder treatments with minimal long-term change. Nadia at times is able to make progress while in these higher levels of care, but not always. And if she does, she loses it almost immediately upon discharge. When she shows up at your clinic, she has recently been fired by her physician for engaging in some very egregious behavior while she was in the hospital. In particular, she called her, and this is a conglomeration of several cases, so it's not one person and in terms of confidentiality. But in this situation, she asked her nurse to come into the room, and while she was there, in front of the nurse, took a handful of pills in an attempt to commit suicide. And her physician said this was it, this was the line in the sand, she wasn't going to see her anymore. She'd been in outpatient therapy for over 5 years, again with minimal change, intermittently being in those higher levels of care. Presenting symptoms include a BMI of 17, severe food restriction and rigidity. She only purges occasionally. She has a significant fear of weight gain, extreme body distortion and satisfaction. But when she shows up, she tells you she is not suicidal, although you know about this incident that just happened in the hospital. She has some comorbid diagnoses. She meets criteria for borderline personality disorder. And as well for post-traumatic stress disorder, secondary to a rape in college and a childhood incident that would be considered sexual abuse. She has significant therapy interfering behaviors, and we're going to define those in a second. Her previous therapists report feeling, quote, burned out and at a loss for an effective treatment plan. And that might make sense certainly after 5 years, and that in this story, her therapist had been seeing her for 2 years. Significant financial and insurance barriers. It's unclear if she can pay for treatment. This is treatment in the States. Her parents have medical guardianship because of her impulsive behaviors and her inability to make progress, and the fact that she becomes significantly medically unstable at times during her treatment and refuses to do what is necessary to resolve that medical instability. And to make the scenario even more complicated, parents interact in a very hostile and aggressive manner with staff, calling and yelling at the front desk, showing up and demanding to see people. They interact in a way where the staff is not excited about working with them. So I call this a difficult to treat case. What generally happens for a case like Nadia? Well, in scenario one, a patient like this entered standard eating disorder treatment, and she indeed has done that. Pros here are that staff is expertly trained to treat her eating disorder. The cons are the staff is not trained or lack protocols designed to manage the suicidal behavior and her therapy interfering behaviors. Outcome in a situation like this, and we've already seen it, these kind of multi-diagnostic patients, they leave treatment prematurely, feel like failures, there's little therapeutic change, and staff reports feeling burned out, frustrated, and ineffective. Now, someone like Nadia could enter treatment for BPD, standard DBT treatment for BPD. The good news there, the pros would be that the staff is expertly trained to treat the behaviors that go along with BPD, in particular the therapy interfering behaviors. The cons are that the staff typically does not have experience with eating disorders or the related medical complications, such that the outcome is these folks may reduce their therapy interfering behaviors and get on top of their suicidality or self-harm, but the eating disorder symptoms typically remain strong. The staff feels frustrated, ineffective, and burned out with the eating disorder symptoms as well. So neither one of these is a great scenario. The goal then, or the framework that I'm going to propose, is that DBT, which is a treatment that balances both acceptance and change, is a treatment that also can balance both the eating disorder and these other comorbid diagnoses. As I promised, I'm not going to talk about DBT extensively, but just to give you, the one or two very long sentence definition, DBT is a cognitive behavioral treatment originally developed to treat chronically suicidal individuals diagnosed with BPD. It is now recognized as the gold standard for treatment of that population in particular, and in addition, research has shown that it's effective in treating a wide range of other disorders like substance dependence, depression, PTSD, and eating disorders. And that's a direct quote taken from the Behavioral Tech website. And if you don't know a lot about DBT and you'd like to learn more, they are the premier training center for. This is Marsha Linehan's group. There are lots of other resources for trainings as well, and if you need those, you can send questions at the end and I will direct you toward them. But I've given you the website there on this page. And I do believe that the slides from this webinar will get posted to the AED website sometime after the end of today. So okay, that's all I'm really going to say about that's not all I'm going to say. I'm fibbing there a little bit. I'm going to talk a bit more about DBT, but very globally. But in terms of thinking about addressing the behaviors of a patient like Nadia, you need to have some assumptions in hand. Now, in order to be able to sort of have the framework with which I'm going to present. Remember that usually when we talk about assumptions, we say it's not a good thing. And you probably all know this saying about what happens when you make assumptions. That being said, there are some assumptions that actually can help, okay? There are some assumptions that, and I like this quote, expectations and assumptions can start either a virtuous cycle or a vicious one. And I'm going for the virtuous one. So there are assumptions in DBT that I think it's necessary for you to have within your framework, because that's what's going to help you think about behaviors such as Nadia. So first, the assumptions fall into three categories. Assumptions about emotion, assumptions about, I'm already forgetting the second one, and assumptions about the therapy in and of itself. So we will review each of those. And don't worry, they're on here, but I'm over 50 and I can't hold a lot of things in my short-term memory. So assumptions about emotion. First of all, that the behaviors you see, the out-of-control behaviors that you see in a patient like Nadia are usually reflective of emotion regulation deficits. And the emotion regulation deficits in DBT are, in theory, caused by repeated interactions between someone who's biologically and emotionally sensitive person, someone who has really strong responses to things that other people just let roll off their back. So these are people who have very strong, intense emotions and an invalidating environment. And an invalidating environment from the DBT framework suggests that they have been met, their environment some way tells them their response is wrong, bad, off, or basically shouldn't be. And that they have developed the behaviors that they developed as a way to manage these emotion regulation deficits. That being said, we might understand that this might be the way that they manage their emotions, but they need to learn new skills to be able to better tolerate distress and manage the emotions that are just a natural part of life. And that any sort of adaptive behavioral response to a particular situation is dependent on your emotion regulation system being intact. Okay, so the first assumption here is that much of the problematic behavior we see has at its cause, has at its root, emotion regulation difficulties. So that's number one. The assumptions about patients. So let me say this though. When we think about assumptions about emotions, when you would think about your list that you had written out that made a patient particularly difficult, and some of us, now I will, in full disclosure, I want you to know that, when I learned DBT, I was trained really first as a cognitive behavioral therapist, which is a huge part of DBT, right? DBT is considered to be cognitive behavioral based, both that change focus of cognitive behavioral therapy as well as acceptance. What goes with acceptance is non-judgmental stance. And we're going to talk about those coming up. But I will tell you that as a cognitive behavioral therapist and sort of as a person in general, the acceptance and the non-judgment is not as easy for me. I have to really work hard on that. And in my experience with clinicians in general, we fall on one end or the other. We can be very accepting and tolerant and non-judgmental, but then we have to learn how to push for change. Or we're really good at pushing for change, and we have to work on being accepting and non-judgmental. Okay, that's my little backdrop here. And you're not alone if you fall in one camp or the other. Most of us do. But when I want you to think about looking back at that list and whether there's any behavior on that list that might be understood within the context of emotion regulation deficits. So if I think that my patient is yelling at me because they're just trying to be difficult, or there's something wrong with them, or even if I take over responsibility that I've done something wrong, I may have a very different response than if I see it as an emotion regulation deficit. Some sort of intense emotion is firing, and now this is how the patient is behaving. I think that having this assumption going, sort of with which to frame those behaviors gives you a very different way. Number one, it gives you a very different sort of emotional response to understanding that behavior, but it also gives you another avenue in for addressing it. So the second set of assumptions about the patients themselves, okay? And these are really key. This is old hat for me now because I've been doing DBT now for about 19 years. And so this is second nature. But for those of you who are not new to DBT, I want you to take this in. Again, having been trained in a medical model and being trained a long time ago, it's possible that training now is different. But these were concepts that were really very different for me, especially in terms of patients with borderline personality disorder. If you've heard me talk about this, I talk about this often. My very first patient when I was a graduate student was diagnosed with borderline personality disorder. And I didn't really know what that meant. I was a first-year graduate student. And when they told me that I was going to be seeing this new patient who was a young woman, I think I was only 25, she was probably 20, and they said, oh, and she has BPD. What is that? Am I going to catch it? Like, what is that? And I asked, well, what does that mean? How am I going to know? And the answer was, oh, don't worry, you'll know. When I'm going into a session with someone and thinking that, you can imagine that it's a very different experience than arriving at a session with a patient who has been diagnosed with BPD, but who we're coming in with these sets of assumptions. Because those people were trying to convey to me a set of assumptions they had about patients with BPD. And those were the nefarious type. Okay? So number one is patients are doing the best they can. They really are. They're doing the best they can. It may not be good enough, but it is the best they can. Patients want to improve. They want to do more. They do not want to live like this. Okay? Patients must learn new behaviors in all relevant contexts. It's not good enough for a patient to learn how to do it just in your office. They need to be able to do it everywhere. Patients can't fail in DBT. We do not tell someone who had an infection and was given an antibiotic for that infection and the infection didn't go away. We don't tell them that they failed the antibiotic. We tell them that the antibiotic failed them. And in DBT, we think the same way, that patients can't fail. But certainly DBT can fail, and you'll see that come up in a second. Patients may not have caused all of their own problems, but they have to solve them anyway. Many of our folks have lived absolutely horrible lives, and that you can maybe understand how they are in the predicament they are in. But it doesn't mean they don't have to solve their problems. They still have to figure out a way out. And that's your job, to help them figure out their way out. Patients need to do better, try harder, and be more motivated to change. So although I told you that they were doing the best they can, they need to do more, okay? Because they have a condition that is usually pretty debilitating and takes a lot of work to make different. And we can say that about eating disorders even if a person doesn't have BPD associated with it. An eating disorder is a difficult illness to recover from as well. This is again key. For many of our patients, their current lives are unbearable. They don't want to live this way. This is one of the assumptions. And this can be, this is very, I feel like I call on this assumption on a daily basis with my patients with eating disorders because of the ambivalence of the illness and the ambivalence about getting better from the illness. Being able to remind myself that although they do get many things from their eating disorder, for many of them, their lives really are unbearable, and they don't want to live like that. They just haven't figured out a way out. Okay, so those are the assumptions about the patients themselves. And then there are some assumptions about therapy. Okay, the most caring thing a therapist can do is help patients change in ways that bring the patient closer to their own ultimate goals, not our goals for them, their own ultimate goals. That's our job. Clarity, precision, and compassion are of the utmost importance in the conduct of DBT. So there's a really pretty specific way that you're going to do this. And you need to be clear thinking, you need to be precise in the delivery of the treatment, and above all, you need to be compassionate. And these are key in the conduct of DBT. And then the therapeutic relationship is a real relationship between equals. This is, again, very different than, I think, the standard medical model where you have the treater and the patient. And the treater knows all, and the patient is meant to learn from the treater. In DBT, it is a relationship between equals. I, as the eating disorder and DBT expert, know those topics, and you know yourself. and we have to be able to work together collaboratively to be able to help you have the life that you want to have. Behavioral principles are universal, affecting therapists no less than patients. So when we talk about learning theory and behavioral principles of reinforcement and punishment, those things impact our patients, but they also impact us. It's a symbiosis there. Therapists need support. In order to do this sort of work, we need our peers, and in DBT there is a structure for that. It's called the consultation team. The notion here, and I would say this about even eating disorders without, again, BPD, is that these are not illnesses that you can treat by yourself. You need a team. DBT therapists can fail, and DBT when therapists do not. So DBT therapists can fail by not actually doing the treatment the way it's written, and DBT in and of itself can fail even when therapists do not. So back to that metaphor of the antibiotic, it may be that even if we give the right treatment, it may not be successful, because that's just a fact of life. Not all treatments help all people. So those are the assumptions, and I want you to have the assumptions when we are thinking about the behaviors that are so difficult for us to manage. Okay. The other piece that you need to understand is a bit of backdrop. In order to be able to address therapy interfering behaviors, is understanding the goals. So the standard goals of DBT are to help the patient move themselves to a life worth living. And the way that we do that, and this is going to be key in a minute, is we are focusing on decreasing behaviors that interfere, number one, with life, okay, being alive, staying alive. Number two, that interfere with therapy. And number three, that interfere with the quality of life. And today's webinar is going to focus on the targets 1 and 2, the decreased behaviors that interfere with living and with therapy. And so I went the right way. There are 4 primary modes of DBT. When we say comprehensive DBT treatment, the DBT that involves all the recommended modes, and that includes individual DBT psychotherapy once a week, group DBT telephone skills coaching, and team consultation. And again, I am not going to belabor these points. This is mostly in terms of backdrop so that we're all on the same page when we start talking about in particular, the DBT individual psychotherapy and how we think about therapy interfering behaviors. So what's my point? Comprehensive DBT provides the framework and tools to address multiple behaviors simultaneously. So how does it do that? And I think that this is the place where there's not usually a day that goes by where I don't think, thank God for Marsha Linehan. When a patient shows up like Nadia to the clinic and has so many multiple behaviors, right? She's in crisis. She was just fired by her physician. She just got discharged from the hospital. She's got a BMI of 17. She's medically stable in this moment, but a history of significant instability. We don't have a lot of time to sort of belabor the treatment plan and sort of think through where are we going to start. DBT offers us a framework with which to be able to really jump in with 2 feet and know confidently, because you have a theory behind you, where you start and what do you do first. So this is where targeting comes in DBT. What is targeting? Targeting is a process that takes the client's goals and transforms it into specific behaviors that we want to increase and decrease. Because if you have any behavioral training, you'll understand that, once we get concrete, this is really goal setting. Once we get concrete, we can know whether we want to increase or decrease that particular behavior, and then we can evaluate whether or not we had an increase or a decrease in that behavior. We make it specific, we make it concrete, and then we know whether or not we're successful. Now, when a client has one problem, okay, like let's say they just have binge eating, and that problem is the focus, that's the target. You are a lucky therapist. And usually, you're able to figure out how to treat that problem, especially if you have the expertise. And perhaps, I just thought about this just now, I don't know if this is really true, but perhaps that's one of the reasons why binge eating is so amenable to treatment. Partly because I think people also really want to get rid of binge eating, but with the absence of purging and the absence of other behaviors, it's a target, and we are lucky and we are successful, and usually that patient is able to move on. When there are multiple behaviors to increase or decrease, there needs to be a mechanism that both helps us with our overall conceptualization, and then also in each session. So we need to have a framework with which we are approaching these multiple behaviors, and in general conceptualizing how they fit together. And then, practically speaking, in each session, we need to be able to know what to do. Now, the other part of the problem is that often the targets move. So when we think about Nadia, and we think about when she shows up, one of the main things, she's telling us she's not suicidal, and she is medically stable. But there's a lot of problems with, number one, is she going to be able to get treatment because she's got financial issues? Number two, her family is interacting with the front desk in a way that makes them not call them back as expeditiously as would be good to get her into treatment very quickly. Her behaviors are starting to increase again because she was just in the hospital, and in that structure she was doing okay, but as she gets out of the hospital without accountability and a therapeutic relationship, she is starting to have more and more eating disorder behaviors. So where do you start? Because guess what? You can't get her into treatment, desk calls back her family, and you can't get her into treatment until you figure out how to resolve her financial issues. So, and then once you do that, then the target yet moves again. So this is the problem in treatment with multi-diagnostic folks, is the targets moving around. And I quite like that graphic. I hope you do too. So how does DBT target behaviors? So the conceptual piece of this is, number one, we focus on behaviors that would, if you engage in them, could kill you, because as Marshall Linehan is known to say, and if you were listening to Glenn Waller, he even quoted Marsha in his first AED webinar, is that you can't get better if you're dead. So you have to focus on behaviors that are life-threatening first. The second is focusing on the behaviors that interfere with treatment, and the conceptualization about that as well. And then finally, the behaviors that interfere with the quality of life. And they are addressed both in session and conceptually in this specific order. So what are these target one behaviors? The you can't get better if you're dead sort of behaviors. These are behaviors that put someone imminently at risk for death. Okay, and those are suicidal behaviors, non-suicidal self-injury, even though those behaviors may not in and of themselves cause death because they're not as sort of defined there. Non-suicidal self-injury, the intent is not to kill themselves. 10% of people who engage in non-suicidal self-injury will die secondary to those sorts of behaviors. So it could move into, and I think I'm going to get to that, and if people have questions about it, I certainly can go back around to that. That's a whole nother hour-long talk. But those non-suicidal self-injury injurious behaviors are considered target one. And the way that we have adapted DBT for eating disorders, and there are several adaptations for DBT for eating disorders, but the adaptation that we've developed for chronically ill and multiply diagnosed folks is that we conceptualize their eating disorder behaviors as target one when they are medically unstable. Because certainly we know that people with eating disorders, there's a high rate of morbidity and mortality, but we really don't know when that death would be. Certainly the risk for imminent death increases exponentially when somebody is currently medically unstable. And we'll talk definitions in a second. So let's talk about suicide behavior. It's important to differentiate here suicide attempts, which is direct from completions, right? And so just so we've got, this is like my public health service announcement. For those of you who don't work in suicide very often, suicide attempt is the effort to intentionally end one's own life, and completion is intentionally ending one's own life. And I think that I've included in my slides a little bit of information about suicidal behavior and eating disorders, because whether or not you realize it, if you work primarily in eating disorders, you are likely working with people who are engaging in these behaviors. So for example, if we think about suicide attempts, so these are non-completers, okay? It's very high rates in bulimia nervosa, but less so in anorexia nervosa. And if you're interested in a great review article, Deb Franco and Pam Keel, I've given you the citation here. It's actually, I think it's Psych Review or Psych Bull, I can't remember. But you can certainly put it in your search engine and find it easily. Did a really nice review. So that when they reviewed the literature, high rates in bulimia nervosa, less so in AN. That being said, it's completely opposite in completed suicide. High rates in AN. Second leading cause of death in AN. Rate is 200 times greater than in the general population. Not elevated in bulimia nervosa. And so my guess is there that someone who has anorexia nervosa, if they're does not do this impulsively. They plan and they make sure that they are successful, in an ironic use of the word. And so we need to be aware that these behaviors absolutely happen with our eating disorder patients. Now, how about non-suicidal self-injury? About a quarter to a half of individuals with an eating disorder, if you look at an eating disorder population, have engaged in non-suicidal self-injury. And if you look at the flip, if you're someone who works with patients who have non-suicidal self-injury, a good degree of them also have eating disorders. So there's a lot of overlap there as well. Now, let's talk a little bit about when we say eating disorder behaviors are target 1, when the behaviors are imminently life-threatening. Now, this is our conceptualization of it. I'd say this is an evolving process, and if people have strong feelings that I've missed something or this doesn't seem like your understanding of what would make someone imminently at risk for death, I'd love to have that conversation, because I think we are continuing to learn. But I have defined here the medical status that we consider making someone's eating disorder behaviors, any eating disorder behaviors, then move into target 1. So if they meet criteria for bradycardia, if they have a significant arrhythmia, in particular a prolonged QTC, or they have electrolyte abnormalities, those are the things we see most common. Chronic ipecac abuse, I think, with now that ipecac is no longer widely available, we see that a little bit less, but certainly given its toxicity and potential for death, would also move someone's behaviors into target 1. So what does that mean? So let's say now I'm trying to think about addressing behaviors with someone like Nadia, and we've gotten her into treatment. Okay, addressing target 1 behaviors in session, so would be my main goal in each meeting that I have with Nadia. Okay, this is the bedrock of DBT. This notion of targets is really one of the bedrocks. The way this works is that in session, if you do CBT, if you already are giving your patient a CBT treatment, you are having them monitor their food. In DBT, we don't call it a food log, but it's a diary card, and the diary cards include, at least the adapted ones that we use, include both recording food intake, but also recording mood and urges for self-harm and suicidality. At the beginning of every session, these the urges and the behaviors are evaluated, and you prioritize target 1 behaviors as needing to get addressed at the beginning of the session. You know, you probably have all had the experience, if you've been working for any length of time with patients who are significantly ill, that you know, patient who shows up late for session, not having done their homework, in tears because they had a fight with their partner in the car, and you find out, you know, if you don't have a mechanism such as a diary card or a self-monitoring form, you find out 3/4 or, you know, unfortunately 9/10 of the way through the session that the patient then brings up that they're also suicidal. And you think, oh my God, now what do I do? That is circumvented when you have a diary card and you have in your framework, because remember, we have a overall conceptualization of targets. We are not going to forget, even if they didn't have their self-monitoring with them, we are going to be asking, where are your urges for suicide? Have you had any non-suicidal self-injury? Have you had any suicide attempts? And that would be part of what we're evaluating at the beginning of each session. Now, the nice thing about DBT, because I think this is one of those questions that are what Marcia also calls moving in where angels fear to tread. Lots of therapists are afraid to ask about suicidal behavior because they're afraid of what the patient's going to say. Like, are they going to say yes, and then what am I going to do? The nice thing about DBT, and perhaps at some point in the future, you know, I'll come back if you'll have me, or if you'll request me to do an overall to do a webinar on DBT in general. But one of the pieces that with DBT is you really don't start treatment until you've got an agreement with the patient that they are going to agree to stay alive for the next year while you try this treatment out, knowing that they already have significant self-harm or suicidal or eating disorder behaviors that put them in target 1. And so when you already have had the conversation, having another conversation about the fact that the patient is feeling suicidal is much less fear-inducing, I think, in the therapist, because you've already talked about it and you already have that patient's agreement that they're going to stay alive. It doesn't mean that they're not going to waffle on it at times, and it doesn't mean that they're not going to change their mind, but you already have an agreement to fall back on, and it is hugely relieving to be able to have that. And the way that these things get addressed, these target 1 behaviors get addressed in session, is by doing a behavioral analysis. And a behavioral analysis in DBT is called a behavior chain, but evaluating, and in that you're evaluating the antecedents to the behavior, the actual behavior, and then the consequences of the behavior, so that you can actively, collaboratively work to be able to patient figure out what they're going to do differently next time and how they're going to stay alive till the next session. Now, I realize that really gives it short shrift, but what I wanted to really make sure we spent a good bit of time on is targeting therapy interfering behaviors, because I think my guess is I think there was like 160 people who are going to attend today. I'm going to guess that not all of them work predominantly with people who engage in suicidality or self-harm as the reason why they wanted to take this webinar. I'm going to guess that most of you are interested in figuring out how to target therapy interfering behaviors, because those, I think, are can be a part of really any treatment of any sort, whether or not you have people who are suicidal as well. And the therapy interfering behaviors are usually also those that, you know, at least in graduate school, they might teach you some ways to be able to manage suicidality. You might have some framework. You've had some class on, you know, what do you do, or you have a supervisor that can help you think it through. Therapy interfering behaviors are really not, you know, addressing therapy interfering behaviors outside of DBT is not conceptualized well, at least that I'm aware of. And I'm going to guess many of you are really interested in this aspect. So target 2 behaviors, what are they? They fall into a couple different categories. There can be therapy interfering behaviors of patients and of therapists, and we're going to review them, and then we're going to talk about what you do about them. So what I've done here is, so I've taken each of the categories, behaviors that interfere with receiving treatment. I should tell you this. So in DBT, the notion of therapy interfering behaviors is if you don't get the whole treatment dose, you don't get the whole treatment. Like if you had that same infection that we talked about before and you were supposed to take your antibiotic every day for 7 days and you miss a couple doses and then you don't get better, you don't know if you didn't get better because that wasn't the right antibiotic or because you didn't actually take the whole dose as prescribed. Same with DBT. So we're going to focus on behaviors that interfere with actually getting the whole dose of therapy. Secondly, you can't get the whole dose of therapy if your therapist gets burnt out. And these multi-diagnostic folks like Nadia, we just saw that Nadia had an incident where she was fired by her physician, someone she'd seen for many years, is that these patients tend to burn out their therapists. And that's a problem, and we need to address that head on and be able to figure out how to better not have that happen so that patients don't lose out on being in therapy. And then the other therapy interfering behavior that you see with patients like this, like Nadia, are behaviors that interfere with other patients, which is why we often in our residential treatments or our inpatient units, when someone arrives with a diagnosis of borderline personality disorder, the staff can be really worried because of the impact that their behavior usually has on other patients, whether or not those other patients also have BPD. Now, because the therapy is a therapy between equals, we also as therapists can have therapy interfering behaviors that interfere. And so those are things that we need to be able to evaluate and address as well. So what I've done on this slide is I have in black listed the behaviors that interfere with receiving therapy that would be applied to any patient anytime, not specific to eating disorders. But our eating disorder patients may have behaviors that if you're not someone who's used to working with eating disorders, you wouldn't be aware of. And the other piece that I want you to think about, just so you're not, well, I guess what the heck, you can look at that slide, is that these are behaviors that historically get people, I'm going to say kicked out, but asked to leave treatment programs, and that if we can have a different conceptualization of them as behaviors that are therapy interfering, and again, remember back to our assumptions, people are doing the best they can, they've got emotion regulation issues, they don't really want to live this way, but they don't know how to do anything different, they need new skills. If we have a different framework, maybe we can address them differently. And so in black is the list of behaviors that are general to any patient, and then in red are ones that are specific to eating disorders. So the first is behaviors, non-attentive behaviors. Things that we normally see, canceling appointments, dropping out, getting admitted to hospital so they're not coming to your session, using substances prior to the session so they're not remembering, walking out, dissociation and seizures, all things that we see in people who are multi-diagnostic and complex, and sometimes even in people who are not, okay? Now, the ones that are specific to eating disorders, and again, I'm hoping to give you another language with which to address these behaviors, both on your teams and with your patients, are not considered non-attentive therapy interfering behaviors. So inadequate intake, resulting in inattention during session. I just had this happen last week with a patient who was, not remembering what we were talking about because she hadn't eaten before session, and she hadn't eaten actually all day before session. Obviously, that's a problem. But that, it was a problem for her that she wasn't sure where she was in terms of resolving. But when she understood that it was interfering with, when we collaboratively discussed it, it was interfering with her attention during treatment, she was willing to make the change to be able to have something to eat before she came in. So inadequate intake resulting in inattention during session. Pacing or standing during sessions, which is usually a calorie burning issue or an anxiety management issue, but it's still really distracting. That's a therapy interfering behavior. Involuntary vomiting in group also is a therapy interfering behavior. And you probably all had these sorts of things come up in your treatment programs or working with folks, but now hopefully you'll have a different language. Then there's non-collaborative behaviors, and again, we're still in the category of behaviors that interfere with receiving therapy. Inability to refuse to therapy, lying, not talking at all, the I don't knows, saying I don't know incessantly. And for our eating disorder patients, we're talking about manipulating weight, refusal to work on eating in session, lying about intake, refusing to be weighed. Okay, if we frame these as non-collaborative and not just, so this is one of the things I want you to think about. I see happen, and it happens for me sometimes, and this is one of the signals for me that I am not in a wise-minded place, and I might be interfering. But I have this feeling when a patient engages in one of these behaviors, and I think you're done. Maybe you're done with treatment, and I see this happen on treatment teams all the time. To me, that is not wise-minded. That looks like emotion, like you could just even see my sort of affect that she's done. And that's going to be therapy interfering, but it's usually as a result of these behaviors because they create feelings in us as treaters, but it's our job to be able to manage those feelings. Non-compliant behaviors, not doing your homework, things again normally that you would see in any patient getting a CBT-oriented treatment, non-compliance. But exercising AMA is, I think, a really good example of an eating disorder specific one, which is refusing to comply with treatment recommendations. And so, sort of being able to target it as therapy interfering rather than, again, grounds for being kicked out or some other sort of way to manage it. Not bringing in food for a therapeutic meal, hiding food, also, again, non-compliant. So then there's the behaviors that interfere with other patients, and the openly hostile, critical, and judgmental remarks. Those are clear, and again, we have a framework. They're therapy interfering for the other patients, and they get in the way of their treatment, and we need to be. That's not okay. We can't do that. So we need to be able to help you contain that. I think the other, one of the things for me that I find that DBT helps me with is being able to explain the rationale, and it's not just because I said so, and it's not just because I think it's a good idea, and it takes the value out of it. But wearing revealing clothing to eating disorder treatment really can be therapy interfering for other patients, and that when patients sort of when it's framed that way, it really takes a lot of the emotion out of the conversation. So then there's the behaviors that burn out therapists. Okay, pushing the therapist's personal limits. Everybody has their own limits, and it can vary over time and with patients. You don't have to have the same limits with all the patients, right? And that's important to remember. DBT really has space for that, and everybody has their own limits. My limits are going to be different than my colleagues' limits. The examples that are listed here in black, I think we would all sort of get behind as problematic behaviors. In eating disorders, what I find, this is my own personal limit, is when a patient continues to lose weight and refuse to collaborate on weight maintenance or gain, that's therapy interfering for me. And if a patient's not willing to figure that out with me, it's going to burn me out, and that's a problem. Then there's behaviors that push the organization's limits. Okay, again, in black are the things that you would see in any treatment program would be problematic. For an eating disorder clinic, vomiting in the lobby restroom where we rent our physical space is a behavior that pushes the organization's limits. If we are unable to help this patient manage that behavior, we could get kicked out of our building. That's clearly therapy interfering to the point of, we might even call it therapy destroying, and needs to get discussed as that. So interestingly, I want you to notice my language when I talk to a patient about this. I might say, listen, I know that you're working on not vomiting, and I know that it's something in general that it's something that you struggle with. We need to be able to figure out how to get you out of the building before you vomit, because if you're vomiting in the lobby restroom, these are the potential consequences. I'm not number one blaming them, and I'm also not going to tackle, are you not going to vomit in your life? I'm really right now, priority-wise, I am focusing on the therapy interfering aspect of that behavior, and I'm solving for that first. So in terms of burnout, the other behaviors that decrease the therapist's motivation, okay? Telling you you're not a good therapist, being hostile, again, these are all the ones that are common. Slow progress, and I put this in both black and in red. I think slow progress, even if we're talking about a patient with, and what comes to mind for me is anorexia nervosa without a comorbid BPD, still can burn out the therapist, because we went into this for a reason. We like to help people, and therefore we like to see change. And slow progress can be something that makes us less motivated because we start to think we're not doing a good job. This can be a direct conversation with your patient in terms of why it's a problem for you. Chronic medical instability due to eating disorder behaviors also can make you feel burnt out and decrease your motivation. And we're going to use that one as a specific example coming up. And I know that I am flying through these, and there's so much to tell, and I wish we had a whole entire day. But I'm hoping that when you leave here, you'll at least have a new awareness of these and a new language with which to approach them. Look, as therapists, we also can be therapy interfering. If we create a therapeutic imbalance of change and acceptance, that's a problem. As I talked about before, if you focus on one more than the other, DBT necessitates us to focus on both. Okay? If we get an imbalance also in terms of being too flexible or not being flexible enough, and then focusing too much on quality or rigidity, that can be a problem, and I've given some examples. I think that what I would like to do, given the time, is talk about the next two slides quickly and then really go into the specifics. And I think we're going to go 10 minutes in, if it's okay, and then do questions and not have a whole half hour for questions. I don't see very many questions coming up, so I'm hoping that this will be okay for you guys. So another therapy interfering behavior of therapists is showing a lack of respect for the patient. Obviously, that would be the case. There are some therapy interfering behaviors of eating disorder therapists that I think warrant a note. Number one is that is different. That wouldn't be in your normal thinking about a therapist being therapy interfering, whereas the other ones are more general. Not staying current in eating disorders and knowing what's going on in the field in general is therapy interfering. Not addressing eating issues as part of treatment. I think especially with comorbid and complex folks, we can lose sight of the eating disorder, and that would be a problem. So not weighing or not asking them to do a food log. And then having your own eating disorder issues that interfere with your objectivity could also be therapy interfering. So now that I know what a therapy interfering behavior is, what do I do about it? Here it comes. It's really coming. Is it doing that on your screen too? Let's try it again. Let's reload it. There we go. Okay, so tips for managing therapy interfering behaviors. The first thing you need to do is clarify the problem in your own mind. Okay, remember I asked you to think about the behaviors that were difficult. One of those, I want you to think about one of those behaviors and see if you can clarify it in your own mind. You may need consultation in order to do this. I did a at the end of last week, and it was on therapy interfering behaviors. And one of the staff members brought up this issue about a patient that she said that the problem as she saw it was that when the patient talked to her, the patient didn't make any sense. And as I helped her clarify what the issues were, it became clear that although that was certainly a problem, and everyone agreed that sometimes this patient did not make sense, that the real problem was that this patient would interrupt the staff member on the unit when the staff member was in the middle of doing something else, and that the staff member had been unable to shape the patient's behavior in terms of limit setting and having her not interrupt her. So if we were going to target the patient not making sense, which certainly is a problem, we'd have a very different set of interventions than if we were just trying to get the patient to stop interrupting when the staff member was in the middle of something. So you really need to clarify the problem in your own mind and get consultation if need be. Then you need to find a way to put this framework in a non-judgmental language before you go to talk to the patient about it. So this actually takes quite, because remember, we are talking about things that for the most part with our folks have usually been punished or handled not well by other people in the past. These sort of behaviors that we're coming up on, things like angry outbursts, things like hiding your food, things like weight manipulation, usually they receive interactions around these behaviors in a punishing sort of way. So we're going to have to be extra careful to put this in non-judgmental language before we go and meet with them. So in my example, when I am in the middle of charting and you see my head down and I'm writing and you come over and ask and want to tell me something, that is really hard for me because I have a hard time getting back into the work that I'm doing, and it would really help me a lot if you would not interrupt me while I'm charting, and I will make sure that I that I come and find you at a later time for us to be able to talk about things. Like, there's a way in which that you can put it in a non-judgmental language. So then you also should, but as part of that, you want to find a non-judgmental or compassionate way to understand her behavior, because that's going to help you, because sometimes the behaviors make you angry, and you really want to find a way to decrease that anger. And if you can, and in this situation in particular, we were conceptualizing that this patient, she wasn't trying to be a pain in the butt. She was really trying to get her needs met. And she also is someone who doesn't have a good handle on social cues. We have a lot of other data to support that she misses social cues. And so she probably has been reinforced for interrupting behavior in the past, because then people pay attention to her and she's just trying to get her needs met. And so if you're thinking about it that way, it's going to be very different than she's just aggravating me. If it's appropriate, take a one-down approach. If it's appropriate. I often do this with my patients if there's a situation where it's like, and in this situation I suggested that the staff member say to the patient, listen, I really let you down because I dropped the ball. Like, you've been interrupting me and I didn't state my needs clearly enough, and I promise you that I'm going to do that from now on. So it's less about you, but you're framing it as, listen, I'm part of this dynamic. It's not just that you're doing this, it's that I wasn't using my skills as much as I could either. So if that's appropriate, that will often help in the delivery of management of therapy interfering behaviors. You want to observe and describe the behavior and why you see it as a problem, and I did that earlier. Confirm with the person that they understand what the problem is. Like, I will often have them back to me, like, okay, what did you hear me say? And now that we are on the same page about this being an issue, are you willing for us to think about what to do? Like, can we work on this together? So I'm not just assuming they want to do it, I'm asking if they want to do it. And then, once we have collaboration, like, yeah, okay, I want to work on that, it's important to me. In that conversation, if you offer solutions, don't give them the solution if possible. It's sort of FBT in that, where you are, some people might do this, some people might do that, some people might do the other thing. Which of those seems like the most reasonable thing for you to try? So we're offering and collaborating, but we're not telling. So hopefully that's clear. It's really hard when I can't see whether or not I'm making sense or not, but I know you're all out there. I can see that you haven't logged off yet. And then again, have patients repeat it in their own words, what they heard and what they think the solution is and what they're going to try differently. You then really have to reinforce appropriate behavior, both in session and later. So I might, in that situation, I recommended that she say to her, okay, let's practice. I've got my head down and I'm going to do when you see that and you really have something that you want to tell me. What are you going to do? How are you going to manage that where you don't interrupt me? Okay, great. And then when in live situation, when she was doing her notes and the patient didn't come up and interrupt her, she would purposely go and seek out that patient and say, hey, thank you so much. I don't know if it came up that you wanted to talk to me, but I was doing my notes and you didn't interrupt me at all. Hey, you have anything you want to talk about? So that you are reinforcing appropriate behavior both in session and later on. So I am for my last slide, and then we'll be done after this. I thought I would show you, because sometimes and this is going to be confusing, so don't even try to unpack it for this minute. When there's a therapy interfering behavior that's happening, and earlier I said to you about, conceptualizing the TIB, and sort of trying to find a sort of non-judgmental way to understand why. Sometimes a picture can be worth 1,000 words, or 100 words, or a lot of words anyway. If it makes sense. This makes sense because I sort of put it out. It's something that I use with one of my patients, and who has been really dancing in between having her eating disorder be life-threatening and not. And it really seemed to be happening often, and it was starting to burn me out. And I had to really think about what was my understanding of why this was happening, because I was finding I was having a lot of judgments about the fact that it kept happening, not the least of which is after a period of time of working together, we still have to see restriction as, oh my God, red alert, because it's making you medically unstable, and then you end up in the hospital, and then there's all these other problems associated with it. And I tried to really think hard about what might be going on, and why was she engaging in this behavior, and why was there such a difference between the way that I was thinking about it with the way that she was thinking about it. And so I came up with this little schema, and I don't know if you can see my pointer, but on the top of the slide, I was thinking about the percent of time the patient was spending thinking and behaving in her eating disorder, where at the left end, 100% of the time really fell in the place of meeting criteria for going to the hospital. And 0 up here, there's some percentage below 0, though, where she would be living a healthy life. And on the bottom, the things that really became a problem for her were her weight and her heart functioning. And on the left, sort of weight functioning, heart functioning very low and weight very low, where she met criteria for the hospital. And on the right, if 100% heart functioning and 100% of ideal body weight, living a full, healthy life. And on the left, and what I think then was happening between us was that my patient, the line here, that sort of straight line up and down, the blue line on the left, where below which she thought her functioning, where her eating disorder was a problem, meant that she already was meeting criteria for the hospital. So once she met criteria for the hospital, then her eating disorder was a problem. And if she wasn't meeting criteria for the eating disorder, it wasn't a problem. Like, it wasn't even partially a problem. It was fine. And in my head, I'm thinking about her living a full, healthy life. And the line for me of her eating disorder not being a problem and her eating disorder being a problem was in a very different place than where she was. And so when I showed this to her, and we agreed that, yeah, this was part of what was going on. And I'll tell you that when you're trying to get buy-in about a therapy and a head nod, like where you're explaining to the patient why you think it's a problem, and they're nodding their heads and they're getting it, then you know you're golden, because now you're really on the same page. But what we agreed to is that if we could find some place in between where she thought the eating disorder wasn't a problem and I thought the eating disorder was a problem, that was far enough away from that line of going to the hospital that it might be something that we could both get behind, that we would be able to target that a little bit more directly. Because until this point, I think that we were really not on the same page, and that was therapy interfering. So sometimes my point is, and again, I hope this slide didn't confuse you, because I just added it last night because I was thinking there needed to be a graph. I was hoping that that was going to help. But sometimes writing it out can be useful. So with that and the fact that it is 12:12, I'm going to stop there. I think there might be questions, and I would be open to those now.
Okay, we do have some questions, and I'm
Ah,
going to read the question and who it's from, and then Lucine will, in her wisdom, answer it.
thank you.
Okay, the first question is from Christopher Lamps in Richmond. How do you handle a patient who will not agree to stay alive?
Well, that would to me be something that would be addressed before I would start treatment with them, Christopher, because if, like, part of DBT is making this agreement, and in DBT you have 1 to 6 sessions before treatment actually starts. We call it the pre-treatment period. So treatment doesn't start until we actually sign these agreements where it says that this is what you're going to do. And there's a lot of motivation and commitment strategies that go into getting the commitment from the person to agree to stay alive. Now again, they may go back on it. And if they go back on it, and that's what you're talking about, and the person says, okay, I no longer agree to stay alive, then they're likely to end up in a hospital because your job is your number one job is to make sure they stay alive. And if they can't agree in that moment, then you're going to need to involuntarily hospitalize them and then backtrack when they come out and figure out what went wrong. But you are going to start with having them make a commitment before treatment even begins. So hopefully that answers your question.
Okay, we have another question. Is DBT considered best practice for AN over BN, or vice versa? Or is it shown to be equally effective in both cases?
Okay, so there's a complicated answer. So DBT so there's a really great book if you're interested in treating folks with binge eating disorder or sort of low-level bulimia nervosa, not complicated by other diagnoses. That was written by Deborah Safer, Eunice Chen, and Christy Telch. There you go. I could even do a Vanna White. There it is. It's a great book. It is for binge eating disorder. It has been designated by the NICE guidelines in the UK that it is a good first-line treatment for binge eating. And I believe they're still looking for a little bit more data for bulimia. When we start to talk about patients with comorbid complex clinical pictures, this treatment is just the skills. And there's some data suggesting that's coming out of Marshall Linehan's lab that just the skills can be useful for people in general without the whole package. Though with eating disorders, this is why I'm sort of like I'm hedging on this answer. So there is a little bit of data on using the treatment that I'm sort of describing, the more comprehensive treatment with all 4 components, with complex comorbid eating disorders with a mix of both anorexia and bulimia. I don't know that we don't have anything that is gold star for anorexia nervosa, frankly. There is also, and I want to give a nod to Tom Lynch's work, and he's in the UK using some skills called radically open skills with patients with anorexia nervosa in particular. But so if the question is BN versus AN versus BN, the science is not that evolved at this point. So it's a long-winded answer to make sure I covered all of my bases, and then to say, yeah, I'm an academic. We don't have enough data yet to answer that question.
Laura asks, due to the egalitarian relationship between the provider and the client and the CBT Foundation, are clients informed of their weight during weekly sessions?
Yeah, so the piece that I didn't go into is that the way that we think about this. So Eunice Chen has done a little bit of work with using standard DBT, just DBT, with patients with eating disorders. The way that we do it is we really do almost full CBT for eating disorders with DBT like integrated in. And so in that way, of course, patients would be weighed every week and know their weight. That's just part of CBT for eating disorders, so that would be part of what we do. But your point about it being collaborative, I think underscores that might be something that would be done even if you weren't using CBT for eating disorders. That would make a lot of sense to me.
Okay, Chloe asks, what do you do when a client cannot come up with goals? The I don't know or I don't care client. Can we make agreements around this kind of interfering behavior?
Oh, Chloe, great question. It's my favorite. I don't know and I don't care are absolutely problems to be solved. Because guess what? They're in your office, so they care somewhat. There's something that they care about. And the I don't knows is, in fact, I have this, here, I'll show you another Vanna White. I actually have this sheet that one of my I don't know patients gave to me. I'm not even sure where she got it from, but I use it pretty regularly to be able to target I don't know. So it's like a million different reasons or a million different things that I don't know might mean. And so in a situation with a patient who is has that therapy interfering behavior, we might collaborate and agree that they would use this paper instead of saying I don't know. It's sort of I don't know, and then it fills in some at the end of it. So absolutely, these would be therapy interfering behaviors, and absolutely they can be targeted. Collaboratively, non-judgmentally, and because they do get in the way of treatment. And my framework is, if you say I don't know, then I don't know. Your job is to be the expert on you, so we have to help you be able to know a little bit better. The I don't care one is usually a link on the chain of some, something happens, some emotion fires, they really don't know how to manage it. Whether it be they're anxious about school, and because of the emotion regulation difficulties and the invalidating environment, they never learned how to manage that anxiety. So they tell themselves I don't care as a way to relieve the anxiety. And that's a link on that chain. That's usually how it shows up. And if you can identify that, then the patient, you'll get a little bit more buy-in on managing the anxiety in the first place, or getting more skillful, or replacing the I don't care with a different thought. So hope that helps.
Rebecca is wondering if you could clarify how having a seizure during a session is therapy interfering. Is this interfering to seizures due to their eating disorder, refusal to care for their health?
Yeah, well, any of those reasons having a seizure. Remember, DBT is non-judgmental in its belief about the etiology. So if you, for example, had, and remember, this isn't if you just did it once. It's sort of like if you were sick and you had a febrile seizure, sure, it's still therapy interfering in that you had a fever and then you were in session because you're having a seizure in its extreme form. But you probably wouldn't target it as therapy interfering because it only happened once. If it happens regularly, and I actually did have a patient where this happened, it became therapy interfering because the person was not attending in session, and it was really distracting. And so we needed to address it. Likewise, we have a patient who had syncope that was happening very chronically. And so although they couldn't find any reason for the syncope, and she really felt like it was out of her control, conceptualized it as, listen, if this is something that you're going to have to live with, we have to figure out a way for you to be able to, they don't come out of absolutely nowhere. We have to help you be able to identify that prodromal period, so at least, the least of which is you could sit on the floor and not fall down and hit your head. And then once we do that, we might get better at understanding what some of the triggers are. But the idea is it's therapy interfering when you believe, number one, that it's completely out of your control and there's absolutely nothing you can do. And non-judgmentally, if it's happening during your session, then you're not going to be able to get what you need out of that session because your brain is altered. So hopefully that answers your question.
So the next question is sort of in multiple parts. So I'm going to start with the first one. What are your thoughts on safety contracts / plans when the patient presents with suicidal intent? That's the first part.
Well, I think we know that those don't really hold up, safety contracts, and that, you know, the way that DBT addresses it is, number one, when you start with a patient, you make a crisis plan. So you collaboratively come up with a crisis plan that the patient is going to engage in if they become suicidal. And so, although I think the piece is you're not going to assume that it's the only thing you're going to do, but you are going to have developed a crisis plan with them, which is different, I think, than a safety plan. I think some people think about safety plans as, okay, you need to agree to me that you're not going to kill yourself. And okay, since you did that, then we're okay. You need a crisis plan. And the crisis plan is, okay, these are my triggers. This is the best way for me to manage my triggers. If I'm feeling suicidal, these are the best skills that help me. If I'm unwilling or unable to do these things for myself, this is the person you can call. And in the worst case scenario, this is the hospital that I should go to if we can't keep me safe. So I think that although you're asking that question, I'm assuming that what you might be getting at there is the notion of okay, I'm signing this agreement that I'm going to stay alive. Those I don't think necessarily are useful. It's the bigger picture, the bigger context treatment that is going to be helpful in a situation with a suicidal patient.
So here's the other part of the question. Also, if the patient has a history of dropping out of treatment when they are hospitalized, and dropping out of treatment is a TBI, and the patient has a history of following safety contracts, but lately the patient says safety contracts work until they don't, what would your thinking be on this?
Yeah, great question. There was a lot in there, but I would say if one of the things we know is that the patient has a history of staying in treatment until they get hospitalized, I would have that front and center, depending on the other targets, as the prime target to behavior. So listen, if this is the treatment that you're going to get that's going to help you have the life you want to have, we need to figure out how you're not going to end up in the hospital. Because if you end up in the hospital, then you quit treatment. And that's a problem. And when you say that safety contracts work until they don't, I get that. And we need a more foolproof plan, because I can't be thinking that you're going to kill yourself if we don't have a plan, because that's not going to work, because that's going to burn me out. And oh my God, I so want to work with you, and I so want to be the person that helps you through this. So will you work with me because this is going to be a difficult problem, obviously, because if it wasn't difficult, you already would have figured it out. Can we collaborate on coming up with something that's going to work to keep you in treatment, not use the safety plan, and not get you to the hospital? Tall order. Okay, are you willing? Let's work on it. So again, it's being objective, naming the problem, and the other thing I would do is, and how great it is that you've already identified some of the things that you know work and don't work for you. So you know that when you go to the hospital, you don't come back. Great, so glad you told me in advance. So glad we didn't go down that path and then I lose you as a patient, because I don't want that to happen. And so glad that you know that those safety plans work only to an extent. Fantastic. Let's figure it out. That would be my thinking.
Well, it appears there are no more questions, so I want to thank Lucine for sharing her experience and insights with us today, and to thank each of you who participated. A recording of the webinar will be available to all members shortly on the AED website, so watch for an announcement also for the next webinar, which will be featuring James Locke in early November. I also want to urge you to spread the word and encourage your colleagues to join AED and take advantage of the many educational and professional offerings, and to join us at the next International Conference for Eating Disorders in San Francisco, May 5th to May 7th in 2016. So thank you everyone for attending. Thank you, Lucine. It was a wonderful presentation.
Okay, thank you. Thanks so much.